Hello, everyone. My name is Dylan James, and I decided to do myeloproliferative neoplasms, or MPNs, for my hematological disorder presentation. So first of all, what is myeloproliferative neoplasms, or MPN for short? First of all, they are just various blood cancers that revolve around overproduction of blood cells or platelets within the bone marrow. Usually manifests in overproduction and can cause blood flow issues as well as other symptoms such as headaches, fatigue, weakness, night sweats, or even hypertension. Was reclassified recently as a cancer in 2008 and was formerly known as myeloproliferative diseases, but not as cancers. Myeloproliferative neoplasms are classified into generally three types: polycythemia vera, essential thrombocythemia, and myelofibrosis. A little bit of demographics behind MPNs. Myeloproliferative disorders are currently unknown to what exactly might cause them, according to experts in the field. Generally, they're assumed to be caused by genetics seen with people with an abnormally shortened chromosome known as the Philadelphia chromosome. Some cases could be caused by the environment or by being or living near things such as chemicals or radiation or even faulty electronic wiring for prolonged periods of time. It's found pretty commonly throughout the world and doesn't seem to be very discriminatory based off whether you're living in a first world country or a third world country. Statistics of the diagnosis have increased over the last 10 years. Total number of around 6,300 MPN cases were reported to the Swedish Cancer Registry between 2000 and 2014. Also, age data found in the Swedish Cancer Registrar is that it affected higher age individuals much more likely than younger people. It's also found that in different types of NPNs affected women more than men, which is kind of interesting. So the first type of MPN is polycythemia vera, which is a very rare type of blood cancer. It occurs when the body makes too many red blood cells in general. Usually its higher red blood cells makes the blood much thicker, causes slower circulation, which can lead to issues with the rest of your extremities getting oxygen and other things like that. It's also very common for people suffering from polycythemia to have elevated white blood cell counts as well as platelet counts. So really anything to do with the whole blood making process in the bone marrow gets elevated. Symptoms for this include excessive clotting, fatigue, headaches, ulcers, or even like very red or purple skin, as well as joint issues such as arthritis or even gout. Diagnosis for this in particular includes blood tests to test for complete blood counts to see how their levels relate to normal levels, a high hematocrit, which is the proportion of red blood cells within the blood itself, hemoglobin concentration as well, which are just proteins found within inside red blood cells that help carry oxygen, low levels of erythropoietin hormone that controls the red blood cell productions. Sometimes tests can also include a marrow biopsy or aspiration to get further information on what exactly is going on, as well as genetic testing, which is testing for the presence of the JAK2, of a mutation on the JAK2 gene, as well as other genetic mutations linked to blood disorders, such as a CALR gene and the LTP gene, I believe is what they are. Treatment of the polycythemia vera. Specific treatments depend on your specific diagnosis and the extent of the disease that you are currently exhibiting. Usually, various drugs are offered to the patient diagnosed for treatment, such as aspirin to help reduce clotting. Phlebotomies may be performed to physically lower the number of red blood cells in the body. Hydroxyurea is a drug given to lower overall blood counts and is given orally under specific conditions. This can help kind of bring your blood count back into normal ranges, or also a genetic drug which targets and inhibits the JAK2 gene that is meant to target the genetic problem linked to the disorder that is linked to creating higher levels of blood cells. The second type of MPN that's most common is called myelofibrosis. This has been classified as a cancer in 2010. Similar to other MPNs, it is developed by the bone marrow making too many blood cells. Myelofibrosis causes scar tissue to form inside the bone marrow itself. There are two types of myelofibrosis, primary and secondary. Primary myelofibrosis develops on its own, independent of anything else, and secondary myelofibrosis develops as a result of other bone marrow disorders, such as polycythemia vera, which is what we just talked about. Either case can result in the body not being able to produce blood cells in a normal fashion. A little is known about the causes of primary myelofibrosis, which is what I'm predominantly talking about. It can occur both in men and women pretty evenly, usually diagnosed in patients over the age of 50. Geneticists and oncologists who study myelofibrosis found that many people with this disorder have a mutation in certain genes, including the JAK2 gene, the CALR gene, or MPL genes. Which are all genes that are linked to coding for a protein that encourages growth of blood cells and creation of blood cells. Symptoms include enlarged spleen, abnormal blood counts, pain in the lower stomach around your spleen area, pale skin, internal bleeding, fever, and joint pain. Myelofibrosis occurs very slowly, so symptoms may not be noticed until further development of the disorder. How you would diagnose MF would be usually to detect mild MF includes things like a complete blood count, ultrasound imagery of the stomach around the spleen area to see if your spleen is enlarged, an MRI or bone marrow biopsy or aspiration, and also genetic tests like before. Results from the blood test would show diagnosis of MF often include a decrease in red blood cells, an increase or a decrease in white blood cells. An increase in platelet count occurs in approximately a third of MF patients. Mild to moderate decrease in platelet counts occurs in another third of MF patients, and in the remaining third, it remains about the same. So it is a little bit of variance in the diagnosis of what you can see in the actual blood count. Treatment of MF has a wide variance and will often include many specialists, including hematologists and oncologists, a radiation oncologist, and a stem cell transplant specialist. Treatments include many options such as chemotherapy to try to kill the cancer-causing masses that can be causing this diseases, cytoreductive therapies, which include drugs to lower blood counts physically and to just try to brute force lower it. Again, JAK inhibitors, which target the JAK1 or JAK2 proteins to help regulate the blood production. Immunomodulators or IMIDs, which fight cancer cells by bolstering the immune system, usually treat symptoms like anemia and enlarged spleen. Androgen therapy, which is a male hormone that is as a male hormone treatment that can increase red blood cell production and can assist in severe anemic patients. Radiation therapy uses ionizing radiation bombardments to kill cells to reduce the size of the spleen. Stem cell transplantation, which is the only treatment that has a chance of curing MF in patients. However, this is a very high-risk treatment and relies on an incredibly specific and suitable donor, so it is very uncommon in this field because it is very unlikely you can find a donor that is, one, willing to have the procedure and give you their stem cells and matches all the criteria you would need them to do for your body to accept those stem cells. The third type of MPNs is essential thrombocythemia, or ET. ET is a very rare type of blood cancer as well as the other two. It occurs often when the body makes too many platelets, not so much in the red blood cells or white blood cells areas, just focusing more on the platelets. Research is still trying to figure out what causes ET. ET occurs more often in people above the age of 50 than below the age of 50, and it occurs more commonly in women than men. About half the people with the disease have an abnormal change in the JAK2 gene as well as the other genes, CALR or MPL, could also be involved, just like the other two. Signs and symptoms of ET. Many people with ET tend to show minimal signs or symptoms. If a symptoms occur, it is likely to include headache, throbbing or burning pain in the extremities, enlarged spleen, thrombosis, bleeding has been recorded as a symptom but is very uncommon. Fatigue and night sweating are very common symptoms. The diagnosis requires a battery of blood tests for a diagnosis, usually consisting, first of all, of a complete blood count. Tests must show elevated platelet levels well above the normal range. Genetic tests are also being done more commonly nowadays to test for the presence of a mutation of the JAK2 gene or other genes related to the mutations, as the aforementioned CALR or MPL genes. Bone marrow biopsy or aspiration helps rule out other causes and used to confirm ET. Treatment specialists in treating ET can include mostly just a hematologist and an oncologist, as well as a pharmacist, because they can prescribe a lot of drugs to assist you. Treatment depends specifically on your diagnosis and what symptoms you are exhibiting, but can include options as just pretty much being permanently put on aspirin to reduce the risk of clotting. Cytoreductive therapies like hydroxyurea, again, to lower your blood counts and given to patients considered a high risk of clotting. Interferon, which can lower blood counts and is given subcutaneously or through a needle or like hypodermically into just below your skin, like an insulin syringe would. All three major types of myeloproliferative neoplasms share many similarities. All three include abnormal rates in which the body regulates the creation of blood cells and platelets. All three of the MPN show various causal links, but one that is consistent between all of them is genetic, which is through that JAK2 gene. And the JAK2 gene is a gene that creates a protein that promotes the growth and proliferation of cells through a signaling pathway called the JAK-STAT pathway, which I believe we've talked about before in lecture, which is very interesting. While you have all these different diseases that are all kind of similar but have different ways of affecting you, can all have this causal link between genetic mutations, and that's why I found researching this was very, very interesting, personally. So, if there's any questions that anyone might have about this, feel free to ask away. And yeah, that's it. Thank you all for listening.